I'm just going to get started with some introductions. So, we already kind of got into a little bit, but I'd like to introduce Shaun Reed, who's an embryologist and fertility lab scientist at Utah Fertility Center. He's been working in IVF since 2014. You may know him from his social media account. He's built a very large following, breaking down different fertility topics on there and giving people a look into what happens in the embryology lab. And we're very excited to have him with us today. We're going to be going over embryo development. So, what are the stages of embryo development in the lab? Genetic testing, so PGT, and then hopefully we'll get to some fun facts as well. And then, if you do have any questions, feel free to drop them in the chat and we'll try to get to them as well as we go. But yeah, we only have 30 minutes, so we have a lot to get through. And then a little intro for me. I'm Claire. I'm head of partnerships at Sunfish. I started out as an embryologist. I was in the lab, and it was excellent. I loved it so much. After that, I moved on to a fertility benefits company, and I've been on the patient side ever since, supporting patients for how they're going to pay for IVF. All right. Welcome, Shaun.
Thank you. Happy
Yeah.
to be here.
Awesome. Amazing. So,
Sorry for the not terribly exciting background. I am at work today in my little office. I just have my official notebook
no,
back
that's
there, the
fine.
boring stuff.
You're in the lab. I love it. Amazing.
Mhm.
Okay, so I guess let's dive right in. So maybe just give people an idea of the IVF process and then where the embryologist comes in to that.
Okay. Yeah. So embryologists come in to play kind of like at the end of everything, right? Like a patient comes in, does new patient consultation. They're kind of trying to figure out what's going on. Why aren't they able to get pregnant? How extensive of treatment do they need? Could it just be timed intercourse? Does it need to be intrauterine insemination or IUI? But if it comes to the point of the patient needing IVF, that's when the embryologist comes in. And even then, it's like they've started the IVF process, right? They've been doing their hormone shots, and then it comes time for their trigger shot for their egg retrieval. The patient kind of comes onto our radar. Typically, that's 2 days before. The clinical side will inform us, okay, this patient is coming through to do IVF. So we get everything set up, paperwork, dishes, and then at time of egg retrieval, that's when I guess we go live with the patient.
Yeah, totally. So the embryologist comes into play once the egg retrieval has been completed. And then walk me through. So what happens in the lab? Once someone does their egg retrieval, eggs are retrieved, they're under anesthesia, they go home to rest. That's when you guys come in. So what's happening in the lab after the egg retrieval for IVF typically?
Mm-hmm. Yeah, I've always wondered what it would be like to have the patient experience with
Yeah.
the embryology lab because they don't really see us, right? It's almost like this mystical. Apparently, there's people back there doing something. Hopefully, they're good at it. Whereas my experience is, yeah, that's my everyday experience all day, every day is in the lab. So yeah, so a patient has their egg retrieval, and I mean some clinics I think the embryologist will come in and like do a patient verification with the patient, like, hey, you're so and so. I'm aware that this is who you are. You're here for your egg retrieval. They might confirm that. So you might see an embryologist for like a minute before you go to sleep for your egg retrieval. Some places don't even do that. It's just like come in the room, doctor, and they're like, all right, you're gonna have a nice nap now. And then once they're asleep, we open the door and the embryologist is there ready. So egg retrieval, the physician's the one. Like embryologists, we don't put hands on patients, right? We don't have that kind of training certification. So it's always a doctor that's treating the patient. They're doing the egg retrieval with that really long needle, aspirating the follicles, ultrasound guidance. When they aspirate the follicles that the eggs grow in, that goes into tubes, and then embryologists are taking those tubes, pouring them into a dish, and looking on a microscope to find the eggs. And that's where the magic starts.
Amazing. Okay, great. And then fertilization. So there are two methods. There's either ICSI or standard INSEM. Can you explain the difference between those two things?
Mhm. Yes, conventional. There's multiple names for conventional IVF, standard for whatever you want to call it. That's where we're going to take the, the the sperm sample and isolate it from semen, or it could be sperm donor. And we essentially kind of we isolate the sperm, put it into some media that makes the sperm really happy. They get really zipping around, and then we just add a lot of sperm to each drop. So eggs and embryos, we culture them in drops of media in a dish. So you got a couple eggs in a drop. We'll just add a few 100,000 motile sperm to that drop, put it back in the incubator, let them go overnight, let the sperm find the egg, fertilize the eggs. The other method, ICSI, which stands for intracytoplasmic sperm injection, is where we're going to manually pick out the best looking sperm and inject one sperm into each egg. So one process is really simple and fast. It takes like 3 minutes to do conventional insemination versus ICSI. Now you're looking at 30, 45 minutes, maybe longer if it's a tougher sperm sample or there's a higher egg count. But yeah, those are the two main, or those are the two only insemination strategies in IVF.
Yeah, exactly. So one is just put the sperm in a dish with the eggs, check the next day to see if the sperm made it in on its own, or there's ICSI where you just inject it
Mm-hmm.
to basically confirm a higher FERT rate. Yeah. So, and then once you check the next day to see how many eggs have been fertilized and become embryos, that's when it begins kind of the process of following embryo development in the lab. So typically embryos are watched until day 5 or 6. Can you walk me through the days of embryo development and what you should expect to see each day for normal development?
Mm-hmm. Yeah, so um, day of egg retrieval is considered day zero. That's the day that we're doing insemination. And then the next day is day one of embryo culture. That's the day that we're doing the fertilization checks to see how many of those eggs fertilized. Um, and the way we see that is the presence of two what are called pronuclei. I think they look like little Ritz crackers that are in the egg. So when
Yeah,
you see
they do
two
look.
pronuclei, it's confirmed that there was successful fertilization. Um, Good slash normal fertilization rates from ICSI is like 80% and above. That's what you ideally should see. Sometimes it happens that it's a little bit lower. Um, Conventional IVF fertilization rate, it can be a bit tougher because this is where it gets a little bit heavier. When we do ICSI, back up even more. When eggs are ovulated, they're surrounded by a whole bunch of other cells called cumulus cells, the big fluffy cloud of cells around the egg. When we do ICSI, we remove all of those cells. We strip the eggs from those cells, and then we can assess maturation. Maturation is like to see what stage in meiosis they are. Some eggs are still immature, not to get like too heavy on the biology. The immature ones we can't inject with ICSI because they're not going to fertilize normally. They need to be at the proper stage of meiosis in order to fertilize. So when we do ICSI, we know what percent were mature, and that can vary patient to patient. Around I don't know 60 to 80% is probably normal range for maturation. When we do conventional insemination, we don't strip those cells away. So all of the eggs that we get, we're going to add sperm and see if they fertilize. So the fertilization rate might seem lower because those immature eggs are included in that batch. So it may feel like a bit of a shock when a patient hears their fertilization report from a conventional insemination, because say they get 20 eggs, maybe 10 or 12 fertilized, and like, oh, that's like 50%. Well, we don't know how many were actually mature. Maybe it was 14 that were mature out of the 20. And so, yeah, 12 out of 14 is actually a good number. Um, that's day one. We see how many fertilize. Like I said, it's usually around 80, 90%. So you're already, IVF is kind of a numbers game. We kind of get into that. So each day you kind of just like drop down a little bit. So you get 20 eggs retrieved, a certain percent are going to be mature. We do ICSI, a certain percent are going to fertilize. Hopefully 100%. Sometimes it's 100%, but it's more like that 80, 90%. So you get a little drop off. Um, and then most labs have moved away from checking the embryos until day 5 after fertilization. Some places still check on day 3. Um, Most of us have just learned there's just not much value in doing a day 3 check. Majority of fertilized embryos will do the first rounds of cell division because the egg already comes with all those factors. Um, so it's just not a good like indicator of how things are going. But day 2, you should expect, we don't check, but you should expect embryos that fertilize to be around like 2 to 4 cells on day 2. Day 3, they're going to be about 8 to 10 cells. Day 4, those cells start to compact together and they kind of form this like amorphous blob. And that's where these cells start doing really cool stuff where they're like communicating with each other. Like, okay, let's start differentiating. You're going to become this part. You're going to become that part. Not like very differentiated. Don't think like, heart cells, brain cells. We're not getting that specific. They're still going to be pluripotent stem cells, but some are going to be designated to the trophectoderm, which becomes the placenta, and the other ones will become the inner cell mass. Those are the pluripotent cells that will really develop all the cells of the baby. So that's around day 4. They get this like, it's called the morula phase, where it's like this amorphous blob. And they may even start to cavitate, which is where there's a cavity that forms in the middle, and then the cells start differentiating and expanding. On day 5, that's where ideally we see them at the blastocyst stage, or just blast. And that's where the cavity expands. You see the cells that are going around the perimeter that are the trophectoderm, and then you've got this nice little chunk of cells that, again, it looks like just a blob of cells, and that's the inner cell mass. But between day 3 and day 5, that's what we say is like a big proving ground for the embryos, because the majority of them will divide 8 to 10 cells on day 3. After day 3, that's the point where the new embryonic genome has to really take over development. And that's where you kind of see the bigger drop off of fertilized embryos making it to the blastocyst stage. And this can vary quite a bit from patient to patient. We usually tell people expect around 50% of those that fertilize will make it to the usable blastocyst stage. Um,
Okay. That's
mm-hmm.
interesting. So if someone gets, let's say someone got like 8 fertilized eggs, they should expect 4 to make it to blast roughly.
Yeah, give or
Okay.
take. And this is where it gets tough because, the smaller the number, statistically, that percentage can seem much more drastic. Um, but yeah, we try and manage patient expectations. So when they hear a day 5 or day 6 update, and they had, say 12 that fertilize, and they hear on day 5 that there's 4 that are ready, they're like, whoa, what did you do? What
Yeah,
happened
where
to
did they
all
all
my
go?
embryos?
Yeah.
Typically, some are ready on day 5, and then some more will be ready on day 6. Some need a little bit more time. So that's where you end up hitting around that 50% mark.
Mhm.
Um, but what's interesting about IVF is that it can be, it's therapeutic and diagnostic sometimes. Um, we say expect around 50%, but some patients are quite a bit lower. They hit like 30%, 20% usable blastocyst rate. And that's where, they start asking, well, what happened? What went wrong? Is there something wrong with the incubator? And no, we're very on top of everything with all the quality control. This is where it becomes diagnostic of, you know, well, you're not getting pregnant for a reason that we're finding, whether it was egg quality, sperm quality, combination of the both. And that's where IVF becomes a numbers game. Hopefully now we've honed in on the eggs sperm combo that's going to give you your best chance of success. We've found the best blastocyst that you've made with this cohort for us to be able to transfer. So I totally understand where it sounds scary and discouraging when you're down to, I only have 3 usable embryos. Yes, but hopefully we've narrowed it down to the 3 best.
Yes. Yeah, and we'll get to PGT in a second, genetic testing and how that narrows it even further. But I am wondering for someone, why? do embryos stop developing? Like when you say it's diagnostic, is there a way to know when at the point that they stop developing whether it's an more of an egg or a sperm issue? Like can it tell you specifics or around like when embryos stop developing? Like is there do you ever know why?
No, unfortunately, because so much of what we do still is just observing. Um, and a lot of patients want that answer. Was it because of the sperm or was it because of the egg? And we don't know. It's likely a combination of the both. Um, there's also like data out there that says it might be more likely the sperm. If an egg or an embryo looked good on day 3 and then just stopped, well, it's like, well, the egg had all the factors that it needed, because if the sperm quality was lower, that's probably where you're starting to see that impact. Um, yeah, that's an answer I think a lot of people would like to have.
Yeah. Okay. Well, hopefully as research continues, we'll learn more. So
Mm-hmm.
now you've gotten to day 5, day 6. Some people choose to do genetic testing of their embryos, so PGT-A. How are embryos tested? I think that there's a common question where like is the embryo being completely sent out to another lab or how is it being tested?
Mm-hmm. Um, so PGT stands for pre-implantation genetic testing. And what we're doing is we're taking those embryos that have made it to the blastocyst stage and we remove a couple of the trophectoderm cells, the cells that will become the placenta. Um, we use a laser, which it starts to sound sci-fi, but there's an objective on the microscope that has a little laser that aligns, and there's a button or little pedal connected to it on the floor. So when you line that laser on like cell junctions and you press that pedal, this laser fires for a microsecond, and that creates heat, which then cuts those cell junctions. So we just grab a couple of those cells, around like 5 cells, and then we use that laser to make a couple of cuts, and then we can pull a couple of those cells off. The blastocyst then gets frozen and it stays uh, here at the lab. But those cells then get tubed and they get sent off to labs that do the PGT testing.
Yeah. Oh, and one thing to note for people is the cells that Shaun is removing from an embryo to test are actually the cells that are going to become the placenta. These are not the cells that are going to become the baby, which I think is really important for people to know because at that stage, it isn't like a few hundred cells in a blastocyst, but that's not a ton of cells. So just so everyone's aware, it's they're testing the cells that become the placenta, not the actual baby. And what is PG testing for? What can it tell you?
It's a screening method. Because we're playing the numbers game, screening becomes then very valuable. So PGT-A stands for aneuploidy. Um, each cell should have 2 copies of each chromosome. And aneuploidy refers to an incorrect copy of those chromosomes, whether there's extra chromosomes or missing chromosomes. So PGT-A is trying to find embryos where aneuploidy is present, because if they're aneuploid, they will either fail to implant or they will miscarry very early. So what we're trying to do is narrow down the embryos that made it to the blastocyst stage that were frozen. Which ones should we select to transfer? Because you don't want to transfer aneuploid ones because those are just going to fail. That's A. PGT-M, that's where you're screening for genetic issues, known genetic diseases. So whether,
Like BRCA, for example, like the breast cancer gene.
yes, and cystic fibrosis are common ones that people are carriers for. So if you know that you're a carrier of a genetic disease, they can build a specific probe for your mutation. Those cells that we send off, then they screen to see if those embryos are affected by that genetic disease or are carriers. And along with that, they can do the PGT-A. So yeah, it's another screening process.
Yeah, and then so sometimes so embryos will come back sometimes and they're euploid, which means they have the correct number of chromosomes, and then the test will come back sometimes and say aneuploid, where they don't have the correct number of chromosomes, so those would not be transferable. What about mosaic embryos? What does that mean when if someone gets an embryo that's mosaic?
Mosaic has become a big topic of discussion in the last 5 years or so. So a mosaic result is where they say that some of the cells that we sent them are normal and some of the cells in the batch are abnormal. Then they can give you a percent of mosaic, like what percent of the cells are abnormal versus normal. And the reason this has become a big topic of discussion is that over the years, as people have gotten mosaic results, because patients run out of options of embryos to transfer, they go, well, let's try transferring your mosaic embryos. And people have had success transferring these embryos, completely healthy, normal babies. Um, so the question is, does mosaic mean do not transfer, or does it mean maybe pick other ones first? Is there really a such thing as an embryo being mosaic, or is this a kind of byproduct of PGT technology that for some reason it's getting a little bit messy results? That was a conference I went to a year or two ago. That was somebody gave it from a genetic lab. She proposed, is it that there are mosaic embryos, or do we get mosaic results?
Mm.
Those may not be one and the same.
Yeah, that's a good point. Interesting. Because people do see success transferring mosaic embryos, right? The success rate is lower than transferring a euploid, I believe.
And I
Still,
think it depends on the percent mosaic. Like if it's a low mosaic, I think people are finding that they have the same success rate. But that could,
okay.
you know, I think that could vary from IVF lab to IVF lab and then PGT company to PGT company. But it's something that the whole industry is trying to figure out and nail down because it's a thing.
Got it. And if people don't do PGT, they decide not to genetically test their embryos, typically the way that it's decided on what embryos to transfer is based on embryo grade, right?
Mhm.
Okay.
Yes. And embryo grading, I always tell patients take that with a grain of salt because embryo grading it's very subjective. Meaning, if I were to take 10 different embryos, pictures, images of 10 different embryos, and I had a room of 10 embryologists, and I said, all right, what's the grade of each one of these? They would argue for hours, probably debating, no, this one's for sure an AB. And somebody would be like, no, right here, see, it's got to be a BB. So you got to take it with a grain of salt. When I was doing my master's, but this is a great example. When I was doing my master's, we had to take an exam on embryo grading. And I was already an embryologist at that point, and I was so frustrated. I was like, you cannot test us on something that's so subjective. And our professor, she had these like all these slides of embryos, and there were always these borderline grade. You could make an argument that it was a BB or an AB, right? And we were getting ready for this exam like the day before. She runs through these slides, and there's this controversial embryo that we were all debating on. And she's like, you guys, it's an AB. That's the answer. Stop. Like, it's for sure an AB. Next day, it's the day of exam. She goes through these slides again really quick. We get to this embryo, and she's like, here's the one you guys argued on. I already told you it's a BB. I'm like, oh, no, yesterday you said it was an AB. See, you cannot test us on this when you would not even pass your test. So don't put too much weight on your embryo grades. I always say if embryologists froze those embryos, those blastocysts, it meant that that blastocyst met the criteria for transfer. And that should give you a sense of confidence that the quality is there. It stands a good chance of success. I've had patients say something like, oh, it's a BB. That means I have a 30% lower chance of success, right? Like, whoa, absolutely not. I don't know what blog post or chat GPT conversation you had, but absolutely not. I may have called it a BB. A different embryologist here may have called it an AB. A different embryologist at another clinic maybe would have called it an AA. So Um, don't put too much weight on it. That example I use of 10 embryologists with 10 different embryo images, they would probably argue about the specific grading. But if I said rank these 1 to 10 best quality, it'd probably pretty quickly everyone would be like, oh yeah, do, 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 do. So,
Okay, that's super helpful to know. So actually like don't like really pay attention too much to the grade. Like if you guys froze it, it's something that's worth transferring. So
mhm.
in general then not looking at grade then because it you don't want it to affect what you think your chances are. In general, for an embryo that's made it to day 5 or 6, what is the success rate on a transfer? Is there a general rate?
It can vary person to person, and the age of, especially the age of the woman at the time of the eggs at the time that the embryos are created can impact it. I think we typically quote around 60%.
Mm.
Um, I kind of struggle with like statistics in our field because ultimately, how does that help the patient to give them a statistic? You have a 60% chance of this working. Well, if they transfer one embryo and they get pregnant, they got pregnant 100%, right? Like you're kind of a sample size of one. Um, I personally think like, and I understand why people want to know stats. They want to know their embryo grade, and patients ask us all the time, "What percent chance would you give me of if I transfer this embryo that I'm going to get pregnant?" I don't know. I see BC graded embryos get pregnant all the time. I see AA embryos fail to get pregnant all the time. So I think information like that, while I would want to know also, I think ultimately it can only like get the wheels turning and like cause you stress versus like you got a blastocyst. Embryologist said it was freezable quality. You did PGT, it came back normal. Your uterus is ready. Let's get that bad boy in there. Fingers crossed. But yeah, quote around 60% probably.
Okay. Okay, so I want to get to some quick fun facts really quickly. So do you have a favorite mind-blowing fact about sperm, eggs, or embryos that patients are typically surprised by when they find out?
Oh, man, I have stuff that like blows my mind, and I don't know if it does other people.
Okay, what blows
Um, was that?
what blows your mind?
I think one thing that's really interesting is epigenetics, which is factors that control the turning on and off of genes, essentially epigenetics, and that's such a like quickly growing field just in general
Mhm.
and in IVF. So one really interesting thing is sperm develop in the testes, right? Like they get a head, they grow a tail, and then they travel to what's called the epididymis. It's like this little structure on top of the testes where they're stored, and they get their final like exposure of components that cause them to be able to be motile and hyperactivated, etc. But in the epididymis, there's these little epididymisomes, these little like packages that come and they bind with the sperm and they have all these epigenetic factors in them. So it's
Oh,
like this last addition before sperm go out of like, hey, you need these factors to like control. And that when
interesting.
ooh,
I did not know about that. I wonder if that's why, like, when someone has to do like a surgical, like a testy or I wonder if that's why the epididymal fluid tends to do better than the testicular, because the
yeah,
sperm are much.
every time I talk to an embryologist, that's the first thought. Like, what about when we do testes and paces? So testes where we
Yeah.
guys with really low concentration or like failed VAS reversals, they'll go and take some testicular tissue, the tubules that sperm grow in, and then we'll see if there's sperm in there. But that means we're skipping the whole epididymis. And I recently read, I guess this is where my mind got blown. An interesting paper I recently read. They looked at in mice, they took sperm from the beginning of the epididymis, because sperm like travel through the epididymis. And it takes, depending on the species, it takes like a different amount of time, like different amount of days or weeks.
Yeah.
So that in mice, they took sperm from the beginning of the travels and sperm from the end of the epididymis travels, and they ejected them into mouse eggs, obviously.
Mhm.
Both groups fertilized the same, both developed into blastocysts the same, but the sperm that were taken from the beginning of the epididymis completely failed to result in successful live births in
Wow.
mice. So in mice, there's this like evolutionary hardcore cutoff of if these sperm don't get epigenetic factors, for some reason in mice, which when we think of mice, these things are like super fertile animals, right?
Yeah.
In mice, won't get pregnant. But in humans, we do it all the time. We get sperm out of the testes and we get healthy babies out of it.
Yeah. That's really interesting. Yeah, there's definitely something there with like the maturation of sperm. I used to do a lot of my research was actually on that, especially like
Mm,
when I was at Cornell. We would do like 4 Tessie cycles like a year that were like I think 3 weeks at a time. It was a lot.
yeah.
Um, so yeah, I did a lot of research on sperm maturation and development. Oh, we actually have a question from a patient. They said, "Can you talk to us a little bit about day 7 embryos?" This person had 7 embryos, day 5, 6, and 7, and 4 euploid. So tell us about day 7.
Day 7 is so standard every lab, I would say, goes to day 6 at least.
Hmm.
Because you have some that are ready on day 5, some need a little bit more time, day 6. Some embryos need a little bit more time and need to go to day 7.
Hmm.
Um, I think years ago, like we were more thinking, day 7, they probably don't have a good success rate at all. Um, more and more people started going to day 7 and transferring day 7 embryos. We now have data showing, yes, they have lower success rate, but it's nowhere near zero. So some labs have switched to standard every patient they take all the way to day 7. Some labs like us will go to day 7 if needed. If there's embryos on day 6 that look like they're progressing but just need some more time, we'll absolutely let them to go to day 7. Um, some patients, it's just really not necessary. Like if use an egg donor, and by day 6 we've already got 12 embryos, and what value is it going to add? It's not going to give any better chance of success to get that BC on day 7. But yeah, day 7 embryos, they work. Um, I think data show that they're a bit lower success rate. I think they quote
Yeah,
around like
because they were too slow.
30%.
Yeah, they were a little too slow to develop. So typically, like day 5 and 6 are
Mm-hmm.
considered on track for development in the lab to become a
Mm-hmm.
blast by day 5 or 6. So
Mm-hmm.
that's what I've read as well in the literature that day 7 tends to have a lower success rate. It can have success, but it is a slower developing embryo than what is expected.
Mm-hmm. Yeah.
Yeah. But definitely, I mean, it ends up being euploid. That tells you something.
Yeah.
Yeah.
Mm-hmm.
Yeah. Awesome. Okay, cool. Well, we're already at the end. We went over a little bit, but I feel like we were getting into like some really fun and
Yeah.
interesting stuff. So thank you so much for joining. Do you want to leave us with a final thing? Like if there's one thing that every patient could understand about the lab side of IVF, what would it be? Like what would you tell everyone?
Outside of IVF. I mean, it's just kind of my, I guess, philosophy of IVF is we're just trying to not do harm in the IVF lab. Current technology, I can't change your biology. I can't change your genetics. I can't change your sperm quality or your egg quality. That's where I've said, selection's kind of the name of the game. We're going to try and find the best looking sperm. We're going to use all the eggs you give us. Um, but other than that, we're just trying to not do bad things. Like we're trying to keep the conditions right, temperature, pH, trying to avoid VOCs at all costs. So yeah, that's how IVF works. I can't improve quality, and I know people try and like give advice on improving egg and sperm quality. Most of it is like avoid the bad things. It's kind of the same thing for you, like don't smoke, don't drink, marijuana's not good. Um, but other than that, is there some? Yeah, be healthy.
Be healthy.
Yeah.
Yeah. Yeah. No, that's a good point. Like you can't improve quality, but you definitely facilitate the development, which is great. So thanks for everything that you do, Shaun. I'm sure that your patients really appreciate it. And thanks for joining today. And everyone, thank you for joining. This is recorded, so it's going to be sent out after the fact as well. And we'll see you all soon. Bye, Shaun.
Thank you. Bye.